Archana?
Ma'am.
Yeah. Can you share the screen?
Okay, ma'am.
Now I invite Professor Hepzibah Kribamani Madam for welcome address. Madam is the now professor in Saveetha University and former superintendent professor in Stanley Medical College, past president of Obstetric Gynec Society of Southern India, vice president of Chennai Menopause Society and India Menopause Society, research member and member secretary of Saveetha University, interested in awareness program, conducts awareness program for paramedical staffs and schools and colleges.
Enough, and we'll go on.
Now we invite Madam for welcome address.
Can I stop sharing it?
Archana?
Yeah. Very good Sunday morning. On behalf of Fetal Medicine Unit of Saveetha Medical College, I deemed it a privilege to welcome you all. Respected Chief Guest, Deepika Desai, Kechwadi Jayashri, our dear colleagues and friends, it's my proud privilege to welcome you all. And I'm extremely honored to welcome Dr. Desai, my friend, fetal medicine specialist, a former Vice Chancellor of SS University of Health Science, Assam, and retired HOD of maternal fetal medicine of AIMS. She was the first one to start fetal medicine in AIMS. She has a lot of awards, and she has won long ago the award for imaging. I welcome you, Madam, and she has received certain Young Scientist Award also. I welcome you. I'm happy to see you here, and I welcome my pride to welcome my friend Dr. Umaram, who is an expert moderator, and I welcome you, Dr. Uma. Warm welcome to all the panelists, Dr. Bhovana, Dr. Rajalakshmi, Dr. Deepa, and Aditi. And I welcome experts in fetal medicine, Dr. Deepthi, Dr. Malti, Dr. Sudarshan, who will sharing their knowledge. And I just want to share one little thing. And because why 21st of March is Down syndrome. It is called a World Down Syndrome Day. This webinar is in relation to World Down Syndrome Day because 3/21 was selected to signify the uniqueness of the triplication of trisomy 21 chromosome, which causes Down syndrome. That is why 21st March is called World Down Syndrome Awareness Day. I'm sure I welcome all the delegates. I'm sure with all the experts that will be sharing their knowledge, we'll be able to know how to screen for Down syndrome. Not only that, how to, the importance of first trimester scan and to go for further management we'll be learning today. And I welcome each one of you once again. Thank you. Archana?
Yes, ma'am.
Share Madam slide.
Yes, ma'am.
Next slide, next slide.
Morning, ma'am. Ma'am, I joined, ma'am.
Yeah, please hold on. Yeah, it's my privilege to introduce Dr. Deepika. She is a senior consultant of Proudland, Gurgaon. She was president Delhi Gynecologist Forum. She's a former professor, unit HOD of maternal fetal medicine, AIMS, and vice chancellor of SS University of Health Science, Government of Assam. She's a past president of Society of Fetal Medicine. She's a past chairman Genetic Fetal Medicine Committee of FOXI, AOGD, ISAPA. She's got numerous publications, 258, and she has edited books, written chapters, lot of awards, right from CL Javri Award, CS Dawn Award, Imaging Sciences, Medical Disorder in Pregnancy. She's got the Young Scientist Award, and so on. It's a privilege to be with the, it's a privilege to have you, madam, and I request you to do the chief guest address.
Thank you, Dr. Hepzibah.
Stop
Can
sharing.
you stop sharing the slide? Thank you, Dr. Hepzibah, for inviting me, and I congratulate you and Saveetha Medical College for organizing this online CME. So, as you said that I have been, since the early 80s, I have been working on fetal medicine. And in those days, it was just starting that we should be aware of genetic diseases, congenital malformations. And it was in those days, I remember that the only way of diagnosing Down syndrome was by low MSAFP. And that itself, and of course, the high maternal age. So in those days, we did not have too many people who were above the age of 35. And all the patients above age 35, we were doing amniocentesis. So to rule out Down syndrome, and naturally you would know that a large number of them would come negative. So as advances came in, we started going on from second trimester biochemical screening to first trimester biochemical screening. Then it was the wonderful work done by the Fetal Medicine Foundation, where we started doing the 11 to 13 plus 6 weeks ultrasound scan, the nuchal translucency. Before that, we were only doing the nuchal fold thickness at 18 weeks. And then after that, of course, we started having so many other markers, the soft markers for Down syndrome and all. Because Down syndrome is becoming more and more common, because a lot of women are actually going above the age of 35 when they conceive. And then the problem is that these children, of course, they can be looked after and rehabilitated, but they are quite, IQ would be less, and they would be some sort of a burden on the family, the society, and the nation. So most of the people, they want that we should have a prenatal diagnosis during pregnancy to rule out aneuploidy. Earlier, it was in the second trimester. Now it is coming down right up to the first trimester. We can do the biochemical screening. And of course, now we have another addition, which is the NIPT, which has greatly decreased the number of amniocentesis or CVS that we are doing. So much advances have been happening in the field of prenatal diagnosis of Down syndrome, that it is very, very important for everyone, all the obstetricians, all the pediatricians, to be aware of how we can do the screening for Down syndrome as early as 10 or 11 weeks of pregnancy. So this CME will really go a long way in educating and updating, unlearning what was learned earlier, and relearning or learning again what is to be done in this 21st century, so that we can prevent the birth of a baby with a handicap like trisomy 1. So I congratulate you all. There are so many things that we can discuss just about this ultrasound screening, the biochemical screening, screening, especially the NIPT. And then, of course, there is this problem of how we can screen in multiple pregnancies, twins, then also higher order multiples, how to screen them. And then what do you do when you first screen and you find? So there are the procedures which need to be discussed: amniocentesis, chorion villus sampling. Even now, a lot of patients are referred very late, with the probable diagnosis suspicion of Down syndrome. And sometimes we may even need to do a cord blood sampling for the rapid diagnosis. We do get a lot of these cases. So it's very important for all obstetricians to be aware about what is Down syndrome, what are the other chromosomal abnormalities, and it should be offered to all women, not only women who are above the age of 35. Recently, I did an amniocentesis in a 26-year-old because she had a very high abnormal biochemical marker, and it turned out to be trisomy 21. So the Down syndrome screening should be offered to all women, young and above 35 also. But especially for the women who are above 35, the non-invasive markers are really a boon, and it prevents the need for amniocentesis in almost 50% of the cases. So all these things need to be discussed. And then the ultrasound markers, you have to be really very careful and knowledgeable how to do the correct measurement of the nuchal translucency, how to look at the nasal bone very correctly, how to do the tricuspid regurgitation, how to do that. And of course, the biochemical markers, how to interpret them, what are the challenges of obesity, then, if IVF pregnancy. So there are so many things that you have to go deep into when you want to have a good knowledge of how to interpret the biochemical markers. And finally, what will you do if the biochemical marker comes out to be positive? Will you do an NIPT? Will you directly go in for an amniocentesis? And then, very importantly, how you are going to counsel the parents. So the counseling part is also very, very important. What you have to tell the parents in their lay language so that they understand. So you must have some module, some, things, pictures of Down syndrome babies, so that you can tell them about what is Down syndrome, what are the problems with having a baby with a Down syndrome, the emotional factors involved, the cost factor involved. So all these things are there. So we have come a long way since the time that the first biochemical and the first ultrasound marker was started. We started doing the occipital, we used to do the thickness of the nape of the neck. And then, of course, we came down from the second trimester to the first trimester, and we are now doing the nuchal translucency and the other biochemical markers. And of course, in the second trimester, we still get a lot of patients who come for the first time in the second trimester. And then whether to do a quadruple marker, there are still a lot of people who are doing double marker and triple markers. So we must know what is the best biochemical marker, what is the best ultrasound markers, how to do them. So I think this online CME is very, very important in today's world. And I wish you all a very grand success. The program is very nice. It's very, very interesting. And I wish you all the best. Thank you again for inviting me. It's an honor and it is a real pleasure. Thank you, everyone. Bye.
Thank you, madam. Thank you for your wonderful message, madam. Now we will go to the first session. And now I invite our chairperson, our HOD madam, Professor Jayashree madam. Madam is a retired director in charge of IOG, past president of OXY, and vice chairperson in AACOG 2015. Received AAL Modelia's award, traveling fellowship award, best paper award in AACOG 1991, given oration and keynote addresses, moderated panel discussions and guest lecture. Now over to madam.
Good morning, everybody. It's my proud privilege to introduce my friend, Dr. Deepthi Jammi. She is a postdoctoral fellowship she has done postdoctoral fellowship in fetal medicine in Tamil Nadu, Dr. MGR University. And her work experiences, she is a director and fetal medicine consultant at Chennai Women's Clinic and Scan Center, fetal medicine consultant at Apollo Cradle, and fetal medicine consultant Anuradha Maternity Center. Her accomplishments are, she has received an award for best oral presentation at New Delhi, and she has got the gold medal for best oral presentation at Mumbai, gold medal in forensic medicine She has received many medals during her undergraduate period. And more than anything, she's a very nice person and she has other interests also. I've been admiring her other videos, which gives some social message. And today we are having Deepthi to give us a talk on anatomical structures, how to define the anatomical structures while doing ultrasound. See, here in Down syndrome, we mainly depend upon the markers, and unless we are thorough with the anatomy, we cannot make out anything that is abnormal. Unless the brain knows, the eyes will not pick it up. So here comes Dr. Deepthi to talk on anatomical structures during the first trimester ultrasound. Over to you, Deepthi.
Thank you, ma'am. Thank you so much. I'm always blessed and honored, both to Jayashree ma'am and Hepzibah ma'am for including me as a part of Saveetha Fetal Medicine Unit. I'll be sharing my screen, ma'am. Thank you so much for the wonderful words. And can you see my screen now? Can I start? Is my screen visible? Can I start, ma'am?
Yes.
Yeah. Thank you, ma'am. So over the next 10 minutes, like how Jayashree ma'am has rightly pointed out, the first trimester evaluation of the fetus is extremely crucial because the first thing, once we evaluate the fetus, and it's only when it's structurally normal, we're going to opt for a first trimester screening or a biochemical screening. If there is a structural evaluation or abnormality in the fetus while scanning, then we are going to go ahead for confirmatory testing. So it's extremely crucial to know what is the normal fetal anatomy, because 97 to 98% of the time, we are going to end up with a fetus having a normal structural anatomy. So only to 2 to 3% of the time, we're going to end up with an abnormal fetus. So once we know, when I learned, when I was a fellow at Mediscan, what sir or ma'am used to tell us was, understand the normal anatomy first. You need to be confident to report a normal fetus. Once you're confident to report a normal fetus, then abnormality will coincide automatically. So the first and foremost thing over the next 10 minutes is to see, why do we need to know how to visualize a normal fetal anatomy in our 11 to 13 week scan. As rightly pointed out by Deepika ma'am and Jayashree ma'am, along with Hepzibah ma'am, the inversion of pyramid of care has come a long way, starting from 1980s or 1990s. What the structures which we were diagnosing as during the anomaly scan time, we have started to pick up those structures as early as abnormalities as early as 12 to 13 week scan. Thanks to the knowledge which we gained through the FMF Foundation and also to the technical support team because of the ultrasound equipment, the high-end ultrasound equipments and the liberal use of transvaginal ultrasound, which makes a huge difference in diagnostic modalities. So also the ISHWA guidelines, specifically when it started off with the mid-trimester evaluation like rule of 3, we also have ISHWA guidelines for first trimester screening as well. So that is what we're going to see over the next few minutes. Early pregnancy ultrasound, we all know that we do early pregnancy ultrasound, one for dating of the pregnancy, to rule out multiple gestation, to rule out an ectopic pregnancy, and to also identify the viability of the fetus. So this all of us know during the early pregnancy before 10 weeks. So what happens when we want to date, apart from dating or accurate anatomy, what else do we do is aneuploidy screening. So along with aneuploidy screening, preeclampsia screening, chorioamnionicity, let's get into detail about fetal anatomy, because I have the upcoming speakers, my next speakers talking about the abnormalities, about the increased NT, what to do next, and also a wonderful panel discussion. So systematic approach. When we talk about systematic approach, the first thing should always come to our mind is a checklist. Without a checklist, do not touch the scan probe, because even an experienced operator who's been doing for years together can miss few anatomy if you are not going to have a checklist. The first and foremost thing, when you touch a probe to do either an anomaly scan, a growth scan, let it be even a dating scan, you have to have a checklist in hand. So what are the checklists which you're going to have in scan? One, for fetal well-being. Obviously, in any obstetric scan, the first thing is viability, placental location, the number of fetus, and also the dating parameters. Apart from dating, the first thing when you think about dating, the first thing you will do is a crown rump length. So this picture should be definitely imbibed in your mind, because the fetus should be in absolutely a neutral position, not a curled up fetus, not a hyperextended neck, only in a neutral position from crown to layer rump is this is the correct way of measuring a CRL. So unless and until we get the CRL correct, we will not be able to go towards the next step. So the first foremost thing in your checklist should always be the crown rump length, date the fetus, look at the environment, then go into the anatomy, because it's very tempting when the fetus is lying down in a neutral position. It's extremely tempting for us to first go and do the NT. No, always have the checklist in mind, drop down the points, tick the checklist, go from outer to inner. Outer to inner, what I mean is start from the environment, check on the uterine wall, check if there are any adnexal masses, check the placenta, check the liga, check the fetal activity, the viability, and then go into the fetal anatomy. So like how we have rule of 3, our system, when we were at Mediscan practicing, we coined something called rule of 2. What is rule of 2? It's easy to remember. From head to toe, we have two structures in each and everything. So when we look at the head, we are going to see each and everything in detail. So let's start with the head. So when we look at the head, as I told you, one, you need to have 2 things, right? Calvarium and the lateral ventricles. So the outer part is the calvarium, because the importance of it you will know in our upcoming talks. The outer part, the calvarium, has to be well defined and established. Then you have the center line, which is the midline falx. Then you also have the choroid plexus. So why do we have to know about it? Along with the intracranial anatomy, let's see the normal intracranial anatomy. This is the picture. Either you take this picture, zoom it and place it near your ultrasound room, because your NT, if you take, should be this picture, because it has to be zoomed. It has to be 75% zoomed in the frame. The upper body of the upper 1/3 of the thorax and the head and neck should be part of the frame, and the fetus should not be hyperflexed or hyperextended. What do we need to know in these structures? One is the intracranial anatomy in the mid-sag plane. The orange color thing, this part is the falx. The round thing is the midbrain. You have 3 spaces and 3 lines. The first space is the brainstem. The second is the intracranial translucency. The third is the cisterna magna, and only then you get the nuchal translucency. There are plenty of times when there are cases reported with increased NT, thinking that it is increased NT, but what would have happened is they would have measured the amniotic membrane. So you need to differentiate. You need to place the probe, allow the baby to jump up and down so that you can actually see the underlying skin and the amniotic membrane separately, so that you measure the correct NT and do not falsely report it as increased NT. So the mid-sag pain, as I already told you, what is the importance? Because only if you know this mid-sag pain properly, we will be able to differentiate or assign the brainstem occipital bone distance. What is the importance of the brainstem occipital distance? So this is the brainstem and this is the occipital bone. And what is the importance is when this distance is obliterated, then you will encounter conditions of Arnold-Chiari malformation, one of the most common condition which we still diagnose during the early, because when you have a checklist or a protocol to make sure that you have 3 spaces, then 2 lines in between, then you know that you are dealing with a normal fetus. And one space is obliterated, that means you know the intracranial translucency is taken off. And here you find, and you can actually diagnose this as early as 12 to 13 weeks, and you do not allow these Arnold-Chiari malformed fetuses to go for termination at 5 months or 6 months during the anomaly scan time. What else? As I told you about the calvarium, obviously the intactness of the calvarium is important. The FARC is important because you should be able to diagnose an acrania or an anencephaly, and also very rare conditions as encephalocele, ventriculomegaly, and also a holoprosencephaly. So since we're going to have a detailed talk about the anomalies later on, I will be going only into the normal structures now. So once we finish with the head, the next is the face and the orbit. So the face, what we have, 2 structures. One are the 2 orbits. Second is the premaxillary triangle. And it's very important that you find the distance between these chin points. So the distance between the 2 mandibular dots is also extremely crucial. So every point in the imaging is very important, which will give you a small clue towards an abnormality. So that's why knowing the normal fetal anatomy is extremely crucial before you jump into abnormal cases. So why you need to know? Because the first and foremost thing all of us are worried about is an unossified nasal bone, where the brightness of the nasal bone beneath the layer of the skin tip is less echogenic than the outer layer. So only then you identify an anosphered nasal bone. What else would you suspect? Obviously, when the mandibular dot is not in the same level as the other dot, then it's probably you would expect a receding chin or a retrognathia. And we've had cases where we have suspected even cleft lip and palate because there is a break or discontinuity in the premaxillary triangle. That's the fetal phase. Then going on to the spine. So what do you see? Two things. One, I've already explained to you the intracranial and translucency, and also the spinal cord. So why do you see the spinal cord? The intactness of the spinal canal is extremely crucial, and also the skin covering the spinal canal is also important, because there are instances where we have picked up a very, very small meningomyelocele or a sacral myelocele in spite of the intracranial anatomy being absolutely normal. So you need to remember there are 3 spaces, then 3 lines, and the skin over the spine. So why do we need to know this? As I told you earlier, that you will also be able to find out once you, instead of 3 spaces, if you see 2 spaces, then you check, go back and redo the spine again and see if you're able to see a small meningomyelocele. Apart from the spine, the next thing what we do is the heart. So even in the heart, there are 2 things. One is the inflow, outflow. The 2 ways how you see is arches, that also has a tick sign. So it's very important that you start with the anatomy by doing the situs. Last week, we've had a case which we diagnosed situs inversus as early as 13 weeks. Why? It is a simple systematic approach where you see the fetus head down, then the spine downwards, then you know that the situs has to be in a clockwise, the left is on this side, so the stomach is here, and the fetal heart, that is the inflow, has to face on the left side. So it is extremely simple, only that you need to zoom the picture, magnify the image, and then you will get it across. So this is the inflow arch, which you can see 2 separate inflows, and also the arches which forms a tick sign. Apart from that, one more aneuploidy marker is the ductus venosus. You have an aliasing sign with the ductus, and a proper 3 to 4 waves is what we need to document. Apart from that is the tricuspid regurgitation. Tricuspid regurgitation, you actually zoom in the same 4-chamber view. You zoom in so that it fits the entire screen about 50 to 75%. Then you put the cursor at the level of the tricuspid valve, and you should be able to get a tricuspid regurgitation properly so that you define whether it is a mild, moderate, or severe. This is a normal fetal heart, and you actually, even just by B mode alone, you'll be able to identify this actually was a date corrected. The fetus was around 14 weeks. You can see in the abdominal size, it is a severe Epstein anomaly or tricuspid regurgitation. So these are the anomalies which we will be able to pick up as early as the first trimester. So when you are looking, have a detailed checklist for ductus venosus. Here, there's a case of absent DV, and this baby, it was as early as 2017, which we found out this baby is around 4 to 5 years now, doing well. So it's crucial that we have a checklist so that we don't miss out on smaller details. Going to the fetal abdomen. When we see in the fetal abdomen, again, 2 things. One is the stomach, 2 is the bladder. 2 anechoic spaces, one in the upper abdomen, the other one in the lower abdomen. The first one is the stomach, and the second one is the bladder. So obviously you'll be able to see in a sagittal view and also in a transverse plane. So documenting 2 anechoic spaces is very important. Why? Because also along with the cord insertion, because we will be able to identify structural anomalies like enlarged bladder or an omphalocyl or even an anterior abdominal wall defect. So apart from the stomach and bladder in the fetal abdomen, we have 2 more things. One, those are the kidneys and the 3-vessel cord. So the kidneys, if you see, this is a transvaginal imaging. So we can actually see the 2 renal arteries, you can see the 2 umbilical arteries, and this is the cord insertion. And here you can see the right kidney and the left kidney properly imaged. The cord insertion is very important because you know that you're not dealing with an anterior abdominal wall defect fetus, and also the bladder anatomy. Along with, because many times we've come across fetuses with megacystis, because megacystis is also a marker for chromosomal aneuploidy when the longitudinal diameter of the bladder is less than 15 millimeter. So another to-do checklist, apart from the lower, so we have started from the head, the neck, then we went to the chest, then the abdomen. So what else are we missing? Here we are missing the limbs, the anatomy of the limbs. So once we've started doing the head, crown to rump, then we go on to the outer. It's crucial that we identify all the 4 limbs, because the earliest scan which we will be able to pick up gross abnormalities are in the first trimester scan, because we need to document 2 upper limbs, 2 lower limbs, and 3 segments of all the 4 limbs. So that's very crucial, because only when you document the 3 segments of all 4 limbs, we will be able to assure them that the limb abnormality is not there. Because this is one of my very, very early cases where 2016 at Apollo, which we found out that this part, the arm is actually, this is around a 13-week fetus, I would say, probably date-corrected fetus. As early as 13 weeks, we'll be able to identify the structural anomaly, because this makes a huge difference for the couple, rather than having a termination at 20 weeks. You are actually avoiding a mid-trimester termination if you are able to diagnose amelia or focomelia as early as 12 to 13 weeks. And even the open hands, we always mention open hands. They are actually very, very easier to see, because the first trimester fetuses open their hands, do not have a fist for so long as in a second trimester fetus. So open hands are very easily visualized during your first trimester scan. So try to visualize open hands if you have time during your first trimester screening. Apart from the limbs or all the anatomy already mentioned, we know that it is challenging. We're not saying no. Yes, expertise is very important. Definitely, once you practice, you have liberal use of transvaginal ultrasound with good quality time, it is definitely achievable. Why I'm saying that is, once you have a checklist in mind, once you've started doing growth scans and anomaly scans, and only then you come to your first trimester scan, once you have a checklist in mind, and once you have liberal use of transabdominal and vaginal, because high BMI and increased thicker anterior abdominal wall is a hindrance towards identifying anomalies, liberal use of a transvaginal ultrasound with a good checklist in hand, you can also use an Ishwak checklist, which is available online, then you will be able to pick up even gross abnormalities, which we are supposed to see in our first trimester scan. There have been studies which have been had gone in detail about the learning curve. Approximately in the number of studies that is the most tedious of the obstetric scans, but with a good use of a transvaginal ultrasound and 3 to 6 months training only in first trimester scan, you can achieve a good expertise level. So what you need to do in a first trimester scan, viability dating. First, start with the fetal environment, then go to the fetal biometry, and after the biometry is when you will go into the fetal anatomical evaluation, and then the aneuploidy screen, which should all be in your checklist covered. So the take-home pointers will be dating, follow, document, and definitely the anomalies which you pick up in a first trimester, unless and until they are detect gross abnormalities, you have to ask the patient to come back at 16 to 17 weeks. Do not take a call if it is not gross, like acroencephaly. Yes, we know it is going to have poor prognosis. But apart from that, if you suspect a cardiac anomaly, or if you suspect, say, even an absent ductus venosus, call the patient back at 16 to 17 weeks for an early TIFA scan or a target imaging. Do not jump into conclusion as early as 12 to 13 weeks, because 2 more extra weeks, the baby is going to grow, and we are going to have more information within that time. We can also have a counseling session with a couple at that time with different pediatric specialties, and also plan our invasive testing. Thank you so much for the wonderful opportunity, ma'am. Once again.
Thank you, Deepthi. It's such a nice lecture, and thanks for insisting upon the checklist. Yes, so that you can have a methodical evaluation by doing a systematic approach. And the liberal use of TVS, don't forget to do that in the first trimester, and you'll be benefited. So once you do for 6 months, 9 months, you will know the difference, and the anatomical defect will be glaring at you, and you will be able to pick it up very easily. Otherwise, you will never see it. True. So the importance of knowing normal anatomy is very, very important.
True.
Thank you, madam. Thank you for your chairing the session. Thank you.
Now I request Mr. Balaji, the program sponsor Vinno company, to play his promotion video.
One moment, please.
No, Nana will lock it. Mask എടുത്തോ. Stand down. Here, Ananya. Here, come, let's go. Let's go. Glasses stand up. வேண்டாம் ஐயா. எங்க இருக்கு?
Thank you very much for showcasing my product.
Thank you, sir. Moving to the next session, the role and limitation of ultrasound detection of first trimester fetal abnormality. I would like to invite my beloved Dr. Professor Nidhi Sharma Madam and Dr. Parimala Madam to chair the session. Yeah, Parimala Madam is she is assistant dean of Saveetha Medical College. She is professor, unit chief, Department of Obstetrics and Gynecology, Saveetha Medical College and Hospital. She is graduated from Raja Muthiah Medical College. She is MS OBG from SRMC, and she is trained in laparoscopy and OB-GYN ultrasound. She has done she is having more than 17 years of experience, undergraduate and postgraduate teacher. She is a mentor and guide. She is external and internal examiner for UG and PG courses. She has participated as a panelist, faculty, speakers in various CMS and conferences, and she has published various papers in index journal. Now coming to Dr. Nidhi Sharma ma'am, she is a MS OBG, diploma in IVF reproductive medicine. She is fellow in Indian College of Obstetrics and Gynecology. She is professor of Obstetrics and Gynec in Saveetha Medical College. She is unit chief also. She is diploma in
Thank you, Archana. We'll move to our session, Archana. Thanks for that.
Okay, ma'am. Okay, thank you, ma'am.
Morning, everyone. Thank you, Archana. It's my privilege to introduce today's speaker, Ms. Dr. Maladi Prasad, who is going to speak on the role and limitations of ultrasound in first timers detecting first trimester abnormalities.
I think we'll go to the topic. Yeah. I think we'll go to the topic.
Okay, madam. Okay, madam. Over and
yeah. Fine. Can I share my screen?
Please, ma'am.
It's not mine.
It's our
I must thank Dr. Hepzibah Madam for this opportunity. Actually, I've been running a temperature for the past 2 days, but Madam encouraged and inspired me to be here. My job has been made easy by the previous speaker, Dr. Deepi, who gave you a checklist of what to do to pick up anomalies in the first trimester pregnancy. Yeah. So what is the purpose of the first trimester ultrasound is to get accurate information which will facilitate the delivery of antenatal care with the best possible outcome, to detect gross fetal abnormalities so that the patient can make a choice regarding termination or continuation of pregnancy, and to assess prognosis in future pregnancies. So it's generally, we always did an anomaly scan. We were all tuned to do an anomaly scan in the second trimester. Now it has been shifted to the first trimester, where you need to pick up many anomalies in the first trimester so that early detection becomes easy for the consultant, because many of the consultants say that the patient has a previous cesarean. If you detect the anomalies 20 weeks, it becomes difficult for termination. So there's an inversion of antenatal pyramid where we very often pick up anomalies in the first trimester of pregnancy. Early fetal development, viability to 13 weeks, embryo till 10 weeks, and fetus beyond 10 weeks of gestation. So based on the EuroCat classification of fetal structural anomalies, there are lethal and non-lethal abnormalities. There are major anomalies. When you find 2 or more major anomalies, call it as a polymalform fetus. When you find more than one minor anomaly, you classify it as per the most relevant anomaly based on the organ system. So viability is establishing gestational age in the first trimester was covered by the previous speaker to assess chorionicity in twins, detect gross fetal abnormalities. So how do we go about detecting the gross fetal anomalies? The first and foremost that early detection and exclusion of many major anomalies, reassurance at risk mothers, and earlier genetic diagnosis. When you do something in the first trimester, we know that there is an option to do a genetic diagnosis by Corinne-Willer sampling and easier pregnancy termination if appropriate. But the limitations of this is that you have limited training. You need to have a lot of training and experienced personnel, uncertain cost to benefit ratio, and late development, for example, of corpus callosum agenesis or hyperplastic left heart may not be detected in the first trimester of pregnancy. So coming to the measurements, measurement was already done. You need to do a complete nuchal translucency. Look at the intracranial translucency is very, very important. When you look at the good intracranial translucency, you know that there is no spinal disorder. When you find an obliterated intracranial translucency, do a complete evaluation of the spine to look for meningomyelocele, because very often we have picked up meningocele in the first trimester of pregnancy. This IT is very, very important, but sometimes you can still have the intracranial translucency and still you have a in a closed spina bifida, you can still visualize the intracranial translucency. So CRL measurements should be done on a mid-sagittal section. The fetus should be oriented horizontally on the screen, magnified to fill the entire screen, and crown and rump should be at 90 degrees to the ultrasound beam. The fetus should be in a neutral position. The endpoints should be defined clearly and avoid inclusion of structures such as yolk sac. So this is how you must take a proper CRL in the first trimester of pregnancy. So coming to a few detailed evaluation of when you do a biparietal diameter and head circumference, you need to take a complete axial view of the head, as you can see in the picture. You have to look at the complete vault, look at the interhemispheric fissure and forks, and the choroid plexus on either side. The choroid plexus should fill from the medial border to the lateral border and should cover more than 50%. When you find it is covering less than 50%, you have to think of a ventriculomegaly. And VPD measurement should be taken from outer to inner or outer to outer. And importantly, look at the cranial bone ossification at 11 weeks. You should be able to see the ossification, and visualizing the vault is very, very important. There should be no bony defects or distortion. The lateral ventricles appear large and fill with the choroid plexus, especially in the posterior two-thirds. And most importantly is that you should be able to see the butterfly sign. If you do not, the dictum is that if you do not find the butterfly sign, think of a holoprosencephaly. You must see the interhemispheric fissure, you must see the choroid plexus on either side, which is otherwise called the butterfly sign. Take a picture and always document it in your reports. I'm just getting into some details of CNS visualization. So this is a complete wall, the interhemispheric fissure, the choroid plexus, you see the lateral ventricles, and this is the third ventricle. Why is it important to look at the third ventricle? You have to look at the third ventricle, you have to look at the aqueduct of Sylvius to exclude early ventriculomegaly. So as we would do in a second trimester, we do the transthalamic, the transventricular, and the transcerebellar. Similarly, you have to do it in the first trimester of pregnancy. So in the transthalamic, you will see the forks and thalami on either side. You see the third ventricle here, and the transcerebellar, you will see the fourth ventricle and the cerebellum and the cerebral peduncles. So you make sure that you give 3 views in a head: transthalamic, the transventricular, and the transcerebellar. In the transcerebellar, you will see the fourth ventricle. The fourth ventricle visualization is very, very important, because if you find a dilated fourth ventricle, you have to think of an aneuploidy, you have to think of early posterior fossa abnormality. So we had 2 or 3 cases of dilated fourth ventricle, did a CVS on the patient, showed trisomy 13. Patient opted for continuation. One of the patient had a normal euploided picture, and we called her back at 16 weeks when we found a Dandy Walker malformation at 16 weeks of gestation. So a transthalamic, a transcerebellar, and a transventricular is very, very important. Do not forget to take all these views so that you get a good view of the head. So it's important to diagnose CNS abnormalities in the first trimester of pregnancy. So this is a normal head. As I said, it's a butterfly sign. The biparietal diameter should be more than the 5th centile. If it is less than the 5th centile, think of a spina bifida, look at the spine. You must find a fused thalamus here, and this is where you see is a abnormal, there's a complete loss of butterfly sign, which is a holoprosencephaly. So taking a complete picture with a forks, interhemispheric fissure, and choroid plexus is very, very important to exclude. Do a transvaginal ultrasound, do not do a transabdominal also, but all these can be picked up only with transvaginal ultrasound. So it should be symmetrical, separated by a clear line. Interhemispheric fissure, the brain mantle is thin. And you must look at the integral translucency. Corpus callosum and cerebellum may not be assessed in the first trimester. So this is fourth ventricle, which you see early cerebellum, and you see a fourth ventricle here. If you find it to be dilated, always think of early posterior fossa abnormalities. No. So what are the abnormalities which can be picked up in the first trimester? One is the anencephaly, as you can see in the picture here, complete loss of cranial vault, acrania, and you find this is now meningocele. It was framed as a meningocele because there were no brain contents inside. And surprisingly, in an acrania, you will find this echogenic amniotic fluid, which can be picked up only via transvaginal ultrasound. So normal fetal brain structures already covered by the previous speaker. Look at the brainstem, PS, brainstem integral translucency, cisterna magna, and occipital bone. This has to be documented in all your reports. So this is a normal intracranial translucency. If it is obliterated, always think of a spina bifida and look at the spine in detail. So next, coming to eyes with their lenses, interorbital distance and binocular distance, hypertelorism when it's more than 95th centile. Invariably, when you have a holopresent cephally, you will find a microphthalmia or hypertelorism. You have to measure the inter and intraorbital distance to exclude and complete your evaluation of the holopresent cephally. Hypotelorism is that where you have, it is less than the 5th centile. So next, coming to the face is important. Have a complete, you have to look at the nasal bone, the complete superimposed line sign in the maxilla, the mandible. All three should be in the same line and they should be parallel to each other. When you find a small mandible or the mandible does not reach up to the anterior aspect of the maxilla, you have to think of a micrognathia. This are the lips, have a complete retronasal triangle, and this is a complete sagittal section of the face. A thorough evaluation will help you to pick up many, many anomalies. This was a case of cleft lip and palate, which we had in a holopresent cephally. You can see the cleft lip and palate here. Always assess a retronasal triangle, cleft lip and palate, and look for any teratomas in the neck. So this was a case of cystic hygroma, and CVS showed Turner syndrome. Patient opted for termination. You will find bilateral jugular lymphatic sacs also. So I'll always keep that in mind. And huge cystic hygroma. I have seen many patients, almost close to 200 patients, cystic hygromas with high drops and non-immune without high drops. And 70 to 80% of women with cystic hygroma and high drops had an aneuploidy. Either it was a Turner's or trisomy 18 or trisomy 21. So I'm going to present this paper of late. And so always keep it in mind when you're dealing with the high drops, always ask for termination because there's a higher risk of aneuploidy. And look for the jugular lymphatic sacs, proper alignment with the neck with the trunk is important. This is 1 minute. And coming to the spine, a complete evaluation of spine anterior is very, very important. And when you have a BPD less than 5th centile, think of a spinal disorder. Always look for intact skin. This was a case of a kyphoscoliosis. She had kyphoscoliosis, ventriculomegaly. It was a limb body wall complex. Patient opted for termination. And this hemivertebra, when you see tiny vertebra in between normal adjoining vertebra, is a sign of hemivertebra, which has to be picked up in the first trimester. Very often you find even in the second trimester, it is not picked up because it becomes easy to terminate when you have it in the first trimester. So hemivertebra should be picked up in the first trimester when you find tiny triangular shaped vertebrae in between adjoining normal vertebrae. And coming to the spina bifida, this was a meningocele picked up at 12 weeks of gestation. Patient opted for termination. You have to say that in a lemon or banana sign is absent in a first trimester spina bifida. You see it only in a second trimester. So do not rely on the lemon or the banana, where you can see that head being absolutely normal, early cerebellum. You do not find the obliteration of cisterna magna, but we found a meningocele here. And this is a small hemivertebra in the same patient, which was picked up with scoliosis. So crash sign. The crash sign is very important, which is when you have open spina bifida, there's a displacement of mesenchyphallon against the occiput, and you find that it's a dry brain. When you find a parallelly placed cerebral peduncles, and always measure the brainstem to occiput diameter. In a normal fetus, it is less than 1. If you find more than 1, think of a spinal disorder. Do a complete evaluation spine where transvaginal ultrasound, if possible, do a 3D ultrasound. And you find that the intracranial translucency is obliterated when you have a very short cisterna magna. So this is a few pictures where it's a normal brain where you find the brain is absolutely dry. There is no CSF at all. This is typical of open spina bifida. There is no third ventricle. There is no aqueduct of Sylvius. So this is a normal brain. We find the third ventricle, normal CSF, and you find an acute sylvius, your third ventricle is absent, acute sylvius is completely absent. So think of spinal disorder. So some cranial signs will be typical where you find a dry brain. When you find absent third ventricle, absent acute sylvius, always think of a spina bifida. Coming to the heart, always make sure that you're in the right position at the left side of the heart. Normal position of the heart is very important. Left side of the chest, cardiac regular activity, 4-chamber view, and arches. This was a case of right side aortic arch, which is diagnosed in the first trimester of pregnancy. This patient had a CVS, showed a DiGeorge syndrome, and they opted for termination of pregnancy. So it's important, as Dr. Deepti said, 4-chamber view, a 3-vessel view, and the arches, when you find many arch abnormalities which we picked up in the first trimester. So always give a twin picture of 4-chamber view and a stomach, so that for documentation, if you have a doubt, you can always go back to your previous pictures to see, you assess your situs. So this was a case which was referred about 2-3 days back with 13-weeker showing the heart, and you find the stomach bubble and few small bowel loops in the chest. So this was a case of congenital diaphragmatic hernia. In the chest, look for lungs of homogeneous echogenicity. There should be no pleural effusion, and the diaphragmatic continuity should be established in all cases. Give an image or picture where you see the diaphragm intact on both sides, and assess the position of the stomach and the liver. This is an apical basal view of the heart with we found the stomach and the bubble loops in the chest, and patient had an amniocentesis. The results are waiting. The patient opted to continue pregnancy because she was age 38 and it was an IVF pregnancy. So stomach and the bladder are 2 spaces which you see in the fetal abdomen on the left side, the levocardia. And next, coming to the cord insertion. Do not forget the cord insertion, because this is a normal cord insertion. This is a case of omphalocele, diagnosed in omphalocele or gastroschisis. This was a 3D picture of an omphalocele which was picked up a few days ago, and patient opted for again a termination of pregnancy. Very often we pick up anomalies in the first trimester, patient goes for termination, no one wants to continue. Next, coming to fetal kidneys, should be seen in the paraspinal location as bean-shaped evaluation should be done. And the fetal bladder should be visible as median hypoechoic ground structure. If you don't find the fetal bladder, call back after 10 minutes. Please look at the fetal bladder. When you find the bladder, you're reassured that the kidneys are present. And when you have a this is a case of megacystis bladder, you see the iliac vessels on either side with hydronephrosis. This patient, we did the CVS and everything is normal. We called him back at 16 weeks. There was a spontaneous resolution of the megacystis bladder, and the patient is still continuing a pregnancy till about 28 weeks, and the hydronephrosis also regular. So when you see a megacystis bladder, if it's 7 to 15, excluded aneuploidy, do not offer termination. But if it's more than 15, then you have to think of a bladder outlet obstruction. So the point of termination or continuation will arise then. But most of the 7 to 15, the spontaneous resolution is seen at 90% of women. So coming to the extremities, as Dr. Deepti said, I'm very comfortable looking at the extremities in the first trimester, because you can have a complete evaluation, hands and limbs. In fact, when they come for the anomaly scan, you don't have to even look at the fingers if you have correct pictures of all the hands and feet. A normal orientation of hands and feet is important. And this is a normal orientation. This is the pictures hidden behind. We had a short limbs at 12 weeks of gestation, and she had a bilateral clubfoot. It was a case of arthrokyphosis because she had a fixed flexion deformity of both feet. She had a previous history of arthrokyphosis. We did a CVS and confirmed her arthrokyphosis, and the patient opted for termination. So always look at the feet. Make sure the feet are moving well. If they are fixed, we have fixed flexion deformity, it is probably a case of arthrokyphosis. And put it in writing and do a clinical exam sequencing. And always try to see, you can nicely see the outstretched hands in the first trimester pregnancy. Many of the hemimelias and amelias can be picked up in the first trimester pregnancy. So the femur length is important. This was a case of arthrogryposis, which is done in the first trimester, and we did a CVS for arthrogryposis. This is a normal orientation of the legs and the feet. This is a normal femur length. And cord vessels, an important number of cord insertion umbilicus, presence of cord cyst, evaluation of paravesical region with the color doctor is important to document single umbilical arteries. Not to forget the placenta. When you do on the first trimester, do not forget the placenta. Look for single or multiple cystic spaces. Subchorionic fluid collection, position of placenta in relation to the cervix. Do not document lower laying placenta as a placenta previa. Evaluation of scar pregnancy, of course, early trimester is very important. And uterine isthmus, the site of cesarean scar. And adnexa, do not forget, make sure the uterus is septate or biconate or the uterine diadelphys. So I've just to summarize what you should not miss in the first trimester is acrania, anencephaly, holoprosencephaly, cystic hygromas, hypotelorism, cleft lip and palate. In the chest, diaphragmatic hernia, the mediastinal shift. In the abdomen, the omphaloceles, gastroschisis, megacystis bladder, and meningoceles in the spine. And extremities, large limb reduction defects, for example, hemimelias and amelia should not be missed in the first trimester. You might miss a few cephalocele. For example, you've done an NT, there's a small meningocele. When they come back to an anomaly, you would have actually seen a small meningocele in an anomaly scan, which has happened to us. And micrognathia, most chest masses, omphaloceles, small ones. And you will definitely miss an agenus of corpus callosum. There are a lot of papers in the Guström Mellinger courses, which I attended about a month back, where they say that you must suspect corpus callosum agenesis at 12 weeks, recall her at 16 weeks, but make a confirmation only at 20 weeks of gestation. So in our setup, I think it's very difficult to alarm the patient that you say that the corpus callosum is not visualized at 16 weeks. So there's a big confusion whether they want to have to continue or terminate. So in our setup, maybe it'll take some time for people to accept. For research institutes, I think you can still document the agents of corpus callosum. Some post-force abnormalities, ventricular megaly, hypotelorism, bowel atresias. Many of the bowels can be picked up in the second or early third trimester. Renal abnormalities, abnormal genders, most spina bifida. So have a checklist. Look at the cranial bones, fox, choroid plexus, neck, eyes with lens, nasal bone. Normal profile, the mandible and intact lip. So when you do a systemic evaluation, always have a checklist on hand. Keep ticking as you see, so that at the end of the day, especially as a beginner, maybe for the first 2 to 3 years, then once you get used to it, you have it in your mind. You have a mental checklist, and you go about completing your evaluation process. So safety, lowest possible power output needed to obtain diagnostic information. B and M mode is safe. Dopplers greater energy, so maybe avoid Dopplers, keep it to minimum as possible. So to summarize, you must pick up the abnormalities, especially seen abnormalities in the first trimester. Do a complete evaluation, like how you do a second trimester anomaly scan. You must do it in the first trimester because it has shifted to the first trimester, so that for the patient's benefit, so that they can make a choice regarding continuation or termination of pregnancy. Thank you, Hepsi ma'am, for this wonderful opportunity. Thank you, ma'am. Any questions I can take up?
Thanks, Dr. Malti, ma'am. It was a very informative lecture. You told us about the choice of continuation, chorionicity, and prognosis determination of the first trimester scans. You told us it's embryo till 10 weeks and fetus beyond 10 weeks. You told us about the corpus callosum and the hypoplastic left heart cannot be detected in first trimester, and maybe a later detection is more feasible. You told us about the intracranial translucency, which can still be normal in closed spinal defects. You told us about the butterfly sign, which is used to diagnose holoprosencephaly. You told us about the transcerebellar view, the transventricular, and the transthalamic views. You told us about the fourth ventricle dilated to diagnose trisomy 30. You told us about the importance of thalamic fusion and the importance of hypertelorism to diagnose trisomy. And you told us to look at the mandible if it is not reaching up to the maxilla. You told us about the hydrops being more associated with Turners and aneuploidies. You told us about the significance of hemivertebra, the tiny triangular shaped vertebrae. You also informed that the lemon and banana sign is seen only in second trimester, and in first trimester it is the crash sign or the short collapse cisterna magna used to diagnose spina bifida. You emphasized the four-chamber view, the three-vessel view with the stomach. You told us about the checking the diaphragmatic continuity and the cord insertions after 12 weeks. And you also told us about the spontaneous regression of megacystitis in 90% of cases. And you told us how to diagnose orthogyrophysis, hemimelia. Thank you, ma'am. It was a great information.
I think there was a question asking how do you differentiate cystic hygroma from jugular lymphatic sacs? The jugular lymphatic sacs are seen on the anterior lateral aspect of the neck. You have to see it on either side, whereas a cystic hygroma will be seen in the posterior aspect of the neck. So that is how we differentiate. But either case, we do a CVS to exclude aneuploid.
Dr. Malati, thank you so much.
Thank you, ma'am.
Of your illness, you are able to join. Thank you so much.
Thank you. You inspired me to join, ma'am. Thank you so much.
Thanks a lot.
Thank you. Thank you.
Thank you, ma'am.
Thank you.
Coming to the next session, thick NT, what next? I would like to invite Dr. Professor Shiva Sundari madam and Dr. Professor Raja Lakshmi madam to chair the session. Shiva Sundari Madam is a MD, DNB, MRCOG. She is Professor of Ops and Gani, Saveetha Medical College. She has obtained 10 gold medals, 13 awards for MBBS. Exam and NOS presented by Tamil Nadu, Dr. MGR, Medical University and Indian Medical Association. She is best outgoing student MBBS and IMA gold medal. OG MBBS MRCOG Dr. Vijaya Patil Prize Medal 2012 awarded by Royal College of Obstetrics and Gynecology, London, UK. She has been awarded with Mr. Chandravati Devi Jagannath Prize for Best Paper in the Oncology AICOG 2015. Best poster is presented a pressure AICOG 2015 and best poster 5 is not enough Oxy 2014. She is the organizing committee a TNRCOG conferences 2016 Mahabalipuram and organizing committee refresh 2017-16 OG Quest 2004 till 2017. I would like to invite you for this session, ma'am.
Thank you.
And Dr. Raj Lakshmi Madam is a professor of Saveetha Medical College. She is undergraduate and postgraduate examiner. She is guide and mentor. Warm welcome to the session, ma'am. Thank you.
May I have the privilege of welcoming Sudarshan sir. He has done his fellowship in fetal medicine 2012, Mediscan Systems, consultant fetal medicine, Mediscan System, Chennai. He has extensive experience in ultrasound and fetal medicine, extensive experience in fetal diagnostic and therapeutic invasive procedures, right from amniocentesis and fetal up to fetal fetoscopic lasers. Then he has been a pioneer in organizing protocols for specialist units in fetal medicine, set up protocols in place for first trimester unit, multiple pregnancy clinic, invasive procedure unit, and been part of, and been running it since 2015 in Mediscan system. Over to you, sir.
Thank you, ma'am. Okay, can you see my screen?
Yes, sir.
Okay. Very good morning, and this session is going to be on the topic of nuchal translucency. If it's increased, what do we do next? This is a question that almost all of us in the obstetric clinic face because of the extensive utility of the first trimester ultrasound, which has indeed been now started being called as no longer the first trimester scan, but the NT scan. I beg to differ with it, but that's a terminology that has come to stay. So the nuchal translucency is a transient subcutaneous fluid collection at the back of the fetal neck, measured between a CRL of 45 to 84 mm, and the nuchal measurement decreases with the advanced gestational age. The cutoff that we use to define a nuchal measurement is increased. Is it a gestational based cutoff of using a 95th percentile or an absolute value cutoff of 99 percentile for all period of gestation? If we start using a gestational age based cutoff of nuchal measurement, the high risk of having false positive increased nuchals would be reported, and hence using either a cutoff of 99 centile for gestational age or an absolute cutoff of 3.5 mm would be more relevant. And why is this nuchal measurement increased? There are multiple reasons for the same. It may be due to alterations in the extracellular matrix, or a disturbed or a delayed lymphatic development, or cardiac failure, or other structural malformations of the baby which impede the drainage of the lymphatics behind the neck of the baby. But let's understand certain principles. This was a patient referred for a second opinion for an increased nuchal. On 19th/11, the nuchal was 3.9 mm, and this patient was referred for a second opinion, and this is the image, and the image is pretty good. And the patient came back after a week for a reassessment, and at that point of time, the nuchal measurement was 2.3 mm. So the point to note is that the nuchal measurement can increase, and the increased nuchal measurement can regress because this is a transient fluid collection. However, even if the nuchal fluid decreases, the higher value is what matters, and we work based on the same. Most important of all, when we want to report a baby as having an increased nuchal measurement, is an audit of the image. There are certain principles and there are certain techniques by which you have to measure the nuchal measurement, and that has been well elucidated earlier. But I want to reiterate the fact that whenever there is a report that you see in the clinic as an increased nuchal, first have a look at the image to see if the image indeed shows a higher nuchal value. I will set two examples. These are two cases. The case on the left side was a nuchal of 3.5 mm, and the case on the right side was a nuchal of 1.8 mm. Both these patients have taken an image again. In a very flexed manner, the nuchal has regressed to 2.7 mm, while when the baby's neck is extended, the nuchal measurement has increased to 2.4 mm. So if we have to obtain an accurate nuchal measurement for the purposes of counseling, we've got to make sure that the imaging is done in an appropriately neutral plane. There are some pitfalls though which can give a false nuchal, especially a baby having a nuchal cord. The presence of the nuchal cord can compress the fluid there, and you may falsely report a high nuchal measurement. And in that scenario, you will have to either take a break or measure the nuchal on either side of the indentation. I have focused significantly on the technique and audit because if we report a nuchal as being increased falsely, the implications for pregnancy management are high. Secondly, if we falsely reassure a patient for a nuchal which is actually was increased but has regressed later on, we would be again facing significant implications to the outcome of the pregnancy. The fourth concept is, what is the ultrasound assessment if you see an increased nuchal? If you look at the clinical evidence, when a baby has got an increased nuchal translucency, and higher the nuchal measurement that you see, higher the risk of structural malformations of the baby. If you look at a specific malformation with respect to the fetal heart, if you have a nuchal of around 3.5 mm, the risk of structural cardiac malformations is around 3.5% compared to a baseline risk of around 0.4%. But if it increases to above 5 mm, the risk of structural malformations nearly becomes 4 times to around 12.5%. So if you have a nuchal measurement over and above 3.5 mm or the 99th centile, refer to a specialist for a detailed structural malformation and focus on the cardiac assessment. If you see a baby with a nuchal that is increased, look at the other markers that the prior speaker has explained to you about. The other markers are namely the ductus venosus flow and the flow across the tricuspid valve in the baby. Because if you have a baby with an increased nuchal and along with it you also have a reversal of the A wave in the ductus venosus, the sensitivity to pick up structural malformations and chromosomal defects is significantly high. So you try to add or you try to rule out the presence of additional markers that will triage the pregnancy as higher or lower risk. If you take this graph, this is a baby having a nuchal of 3.8 mm. But if this baby also has got a tricuspid valve regurgitation and a ductal reversal, the risk of cardiac malformation increases from around 15% to around 70%. So higher the number of markers, higher the risk of structural cardiac malformations. This is a baby having a nuchal of 4.4 mm. And this baby also had a cardiac axis deviation, and a very detailed transvaginal assessment showed that the baby indeed had a cardiac anomaly, which was a tetralogy of Fallot. So the point to again reiterate is that a detailed structural cardiac assessment can be done if you do a transvaginal ultrasound in a baby with an increased nuchal. But is it all about the fetal heart? If you see a baby with a larger nuchal, there can be other structural malformations. It can be a common condition called a diaphragmatic hernia. And mind it, this can present in later gestation also. There can be skeletal dysplasias. There can be ultrasound markers of chromosomal abnormalities, or a baby can have a cystic hygroma or a jugular lymphatic dilatation along with the hydrops. So what is the clinical evidence for the same? If you look at a baby having a nuchal of more than 3 mm, the risk of structural malformations is around 11%, while it becomes more than 4 mm, it increases to over 25%. And common structural malformations I have elucidated in the previous slide, but it can be, babies can be associated with a cleft lip, omphalocele, skeletal problems, diaphragmatic hernias, in addition to cardiac malformations. This was a scenario of a baby with an increased nuchal collection. The nuchal was close to 10 mm. The baby also had features of hydrops, cardiac anomaly, and short limbs. A tentative diagnosis of a short limb with polydactyly was made. Autopsy was ordered after storing the fetal DNA, which confirmed the pathological diagnosis of a short rib polydactyly syndrome. And hence we are able to target the genetic testing towards this specific problem. The key message to note is that if you have a baby with an increased nuchal and the baby has got a structural malformation, specifically with respect to skeletal malformations, perinatal pathology adds additional value. Hence, order that. Do not think that a simple karyotype would do. It won't give additional information for the family with respect to these specific malformations. When you look at aneuploidies as a whole, this is a graph that shows the risk of nuchal translucency in aneuploidies. If the nuchal increases from 3.5 mm to 6.5 mm, the risk of chromosomal abnormalities increases threefold from around 20% to 60%. To put it in numbers for a patient, if you find a baby with a nuchal of 3.5, you can tell the patient that there is a 1 in 5 chance of the baby having a chromosomal abnormality. And if the 6 mm, then there is a 1 in 2 chance of the baby having a chromosomal abnormality. So when you look at this compendium of graph again, which shows very, very clearly the association with both chromosomal abnormalities and structural defects, which shows an exponential increase from a nuchal of 95th centile to above 6.5, where you see an abnormal karyotype and structural defects from around 10% to close to 70%. These chromosomal defects are not necessarily trisomy 21 alone. They can be trisomy 13, 18, Turner syndrome, and even unbalanced translocations, which means a very detailed structural assessment will help you. This baby had a very detailed structural assessment which showed multiple markers of trisomy 13, and hence a targeted testing for only a karyotype was feasible to be done. Let me put across a couple of cases to understand this further. This was a second gravida who had come. First pregnancy terminated due to twin transfusion syndrome stage 4. Second was referred to us for a nuchal of 3 mm. The nasal bone was seen for a CRL of 54 mm. They had done a double marker or a combined test which showed a low risk for trisomy 21, 1 in 444. If we recalculated, it would fall under the intermediate subgroup, and the PAP-A mom was low. They were referred for a second opinion. The nuchal had regressed in the next 5 days to around 2.5 mm. What should we do next? Should we simply reassure them screen is negative, or offer further assessment like a non-invasive screening for aneuploidy, or simply offer a definitive testing because a nuchal of 3 mm was 99 centile for a CRL of 54 mm. The patient wanted NIPT alone. They did not want a direct test. The NIPT showed a high risk for trisomy 21, and karyotype showed that it was a pure trisomy 21 despite a normal scan. The key message is the increased nuchal can regress even if the screen risk is intermediate or low risk. When a baby has got an increased nuchal, then you would need to think of offering a karyotype because screening tests only give a risk prediction. Let's continue this case because this patient came to us for the next pregnancy after doing a parental karyotype which was normal. At this point of time, at 13 weeks, the nuchal was 3.7, the nasal bone was absent, the ductus venosus was reversed, and a karyotype was done, again, a recurrent pure trisomy 21. The key message to pass on is if you see one marker, namely an increased nuchal, look for other markers, and if the NT is high, no screening test. Pure trisomy 21 has a recurrence risk of less than 1%. It's uncommon, but can happen. If the nuchal is extremely high, the risk of these chromosomal abnormalities lessened, but the risk of Turner syndrome becomes very high. Specifically, this may have a smaller left heart and an aortic arch. And you can see this is how a nuchal edema looks on the autopsy picture, and a karyotype again was proven to have Turner syndrome. If you look at nuchal and multiple pregnancy, if you have a dichorionic twin and one baby has got an increase, I'm hearing a lot of disturbance. Can someone mute their mic, please? If you have a dichorionic twin with a nuchal of increase of 3.8 in one baby and a nuchal normal of other baby, avoid any form of biochemical screening because it wouldn't give you clarity. Offer invasive testing, ideally a CVS for the twin with an increased nuchal, and depending on the test results, further management needs to be followed. But if it's a monochorionic twin with one baby having an increased nuchal, do a detailed structural assessment of the baby. For instance, this was a monochorionic twin. Discordance for a nuchal translucency. Discordancy was close to 50%. That baby with an increased nuchal also had a cardiac anomaly. So look at the structural assessment, because though monochorionic twins are usually concordant for karyotype, they can have differing structural malformations, and around 1% can even have a different karyotype. Review at 16 weeks, assess for the genetic cause, and offer testing and various further options. What if the karyotype is normal? Will that reassure us? Because we saw that this constitutes around 20% of the problem. Is there any further assessment that we need to do? If you look at a baby with increased nuchal, this is an example of a baby at 9 weeks had a nuchal edema. They referred to us at around 12 weeks. At that point of time, the nuchal was 5.4 mm. This was a non-consanguineous couple with an IVF own embryo. NT was 5.4. A CVS was done that ruled out the common aneuploidies 13, 18, 21 and Turner syndrome. We proceeded forward to do something called as a chromosomal microarray analysis, and that showed a pathogenic copy number variant or a duplication of 7q chromosome. And this condition is associated with varying developmental intellectual delay. So a parental assessment was done thereafter, and that was done by a technique called as a prenatal BOBS that showed that the husband had, Mr. S had the same 7q duplication. And then we consulted the genetic team, and the evidence that came across was that 7q duplication can have variable expressivity with mild to varying impairment. The husband was normal. The options for the next pregnancy, because it is a dominant condition, is we can offer PGD on the stored embryo. So the key message is assessment of the etiology by advanced genetic testing helps provide options for the next pregnancy. And if you look at the chromosomal microarray, what additional value does it bring? In babies with isolated increased NT, 4% additional value. If the baby has got associated structural malformations, close to 7% of additional information that the karyotype does not provide. And these pathogenic copy number variants can be varied. It can be 22q deletions, duplications, 7q as I showed you, or various others. Lastly, we come to nuchal and single gene disorders. This was an example of a patient, fifth gravida, 2 live children, 2 abortions, again an IVF pregnancy. Nuchal was 5 and there was septations. Structurally, the baby was normal. So what do we discuss? We learned that we have to do a detailed anatomical assessment. We have done it. It's normal. We learned that we have to rule out common aneuploidies. We ruled it out. And at that point of time, we also provided options of further genetic testing. We will see how it is serially to be done. An option of continuation or termination was done because the baby had a cystic hygroma, and this patient opted out of pregnancy continuation, but they wanted testing. How was the testing done? Step 1, we did a QF-PCR that ruled out the common aneuploidies. Once this was ruled out, we did something called as a maternal cell contamination study to make sure that this is fetal cell alone, because that is necessary for further genetic testing. And this showed it was normal. Further genetic testing on the stored DNA was done. The DNA was stored and extracted. The point to reiterate is, if the nucleus is high, always store the fetal DNA. And on that, we did something called as a chromosomal microarray. We saw that in the previous case. In this particular case, it was completely normal. The parents wanted further genetic testing even further, and hence a whole exome sequencing to look at gene deletions and duplications were done, which also showed a normal report in this. Key message to note is that serial assessment is done with an increased nucle, a QF-PCR, a microarray, and a whole exome in stepwise order if the structural anatomy is normal and no other information is seen on the family pedigree. But sometimes certain genetic disorders are not picked up even on this, and you may end up with no result. So the point to note is single gene disorders like Noonan syndrome and things which I showed earlier can be associated with increased nucle. Most single gene disorders are usually sporadic, and hence you cannot think of a nucle as a generic marker for single gene disorders and do a gene sequencing for everyone. Do always a stepwise assessment. Once we have done all this 3-level testing and everything is normal and the nucle is regressed, wants to know, will my baby be having a normal mentation at birth? The answer for this is there based on the evidence that overall risk of neurodevelopmental delay in a baby with an increased nucle with normal testing which is done in a sequential manner and a structurally normal scan after the nucle has regressed, it is only 1%, that is almost equal to the baseline population and control group. So with this information, how do we counsel the parents? Question 1, what is the cause of the increased fluid? We can answer that after we do a detailed scan, and we can tell them it can be due to these structural malformations, chromosomal or genetic defects. What if the karyotype is normal? We now know that we've got to do serial genetic testing using a microarray or a whole exome sequencing, but always involve the genetic team in that. We have evidence in front of us to counsel patients on the risk of adverse pregnancy outcomes depending on the level of increased nucle, which I have reiterated in the slides earlier. So if we have this flow chart, it would make our job easier. Say the nucle is above 3.5 mm. Do a detailed anatomical scan, an early cardiac screening, and look for markers. If everything is normal, offer a CVS for a QF-PCR, ruling of common aneuploidies, and store the DNA. If the baby has got structural abnormalities or height, and if the QF-PCR or BOBS is normal, then you have to do an early assessment for anatomical evaluation at 16 weeks, rule out high drops. Do a microarray testing and a Noonan and gene sequencing. Do a detailed anatomical scan and an echo at 20 weeks and follow up the baby and assess the baby postnatally. However, if the baby has got structural malformations and high drops, do a baseline karyotype, store the DNA. If the autopsy is feasible, based on the information, direct further genetic testing. Key messages are: number 1, audit the image. 2, follow protocols in assessment. 3, discuss options to the couple with evidence. Avoid prejudice, avoid offering termination for every baby with a nucle of 3 mm. Do a detailed family pedigree and a parental assessment because it adds value. Testing must be tailored to individual findings, always involve the genetic team. Though there are uncertainties, if there is a regression of the entity, if the fetus is structurally normal by 20 weeks and there is normal genetic testing, there is a high chance of a normal perinatal outcome, and the situation is not bleak in every single baby with an increased nucle. Thank you so much.
Thank you, sir, for enlightening us with management of increased NT. So to summarize, you have told us about management of increased MT. If there is an increase in nuchal translucency, then look for other markers. and work with initial NT assessment. If there is multiple pregnancy, that is DCDA twin with one discordant NT, avoid biochemical screening and do invasive testing for affected twin, and audit the images and follow the protocol, discuss and counsel the patient, and you can go for advanced genital testing like chromosomal microarray. Thank you, sir, for enlightening us with your presentation.
Moving to the next session, I feel great privilege to invite Dr. Umar Ram ma'am as a moderator for the next session, case-based discussion, early abnormal pregnancy. We are honored to have you here, ma'am. Ma'am is DNB FRCOG FICOG Director and Consultant, OB-GYN, Saveetha Clinic and Hospital, Chennai. She is a chairperson, South Zone AICCR COG examiner. She is Part 3 MRCOG Treasurer, 18 RCOG. She has contributed chapters and edited books, publications, GDM and multiple pregnancies. She is a reviewer of JOGI, AOGS, JDDC. She is having interest in areas of high risk pregnancy, fetal growth, benign gynec health awareness in women. Ma'am, may I request to introduce the panelist, ma'am?
Thank you very much. Am I audible?
Thank you. Yes, ma'am.
Yeah, thank you very much. At the outset, I'd like to thank Dr. Hepzibah for this invitation and for a very, very informative session so far. So in this panel, we are going to talk about some issues of abnormal early pregnancy. We've heard a lot about how the scan at 11 to 13 weeks is beyond NT, how much of abnormalities can be detected. So we are not going to talk about fetal structural abnormalities per se, but we'll discuss some other issues here, which may be...
Sorry to interrupt you, ma'am. Can I introduce the panelists?
I'm going to introduce the panelists, don't worry.
Okay,
yeah?
Okay, ma'am.
So
Thank
in
you.
order to help us navigate these clinical situations, we have 4 panelists. The first I'm introducing is a good friend, and we go back to medical school, Dr. V. Rajalakshmi, who's currently professor at Stanley Medical College and superintendent in charge of government RSRM Lying in Hospital. She's a very, very dedicated teacher and a clinician and has been received awards for the same. So has a wealth of experience. The next person we have on the panel is Dr. Bhuwana. Bhuwana is currently Associate Professor and Senior Consultant at Sri Ramchandra Medical College and Deemed University. She has a brilliant academic career and is a very dedicated teacher, both a UG and a PG examiner with many publications to her credit. We have Dr. Deepa Thangamani, who is a very, very dedicated clinician. She currently works at Apollo First Med Hospital. She's very active with the 18 RCOG group and is the joint secretary and is the clinical examiner for Part 3 MRCOG and is also the joint secretary of the Chennai Menopause Society. We have with us Aditi Dubey, who is done her fellowship in fetal medicine and a fellowship in prenatal genetics. She's trained actually all across India. I realize she's trained in, she's done her schooling in Gorakhpur, she's trained in Pune, Faizabad, Kerala, Lucknow, and she's just recently completed her fellowship in prenatal genetics from SGPGI Lucknow, and she brings with her all that learning experience. So with this brief introduction of the panelists, we move on to the clinical scenarios. So the first is a primip who presented to us 2 years ago. She had her last menstrual period on the 30th of June 2020, and 2nd of August, because she was going to travel abroad in a week, she decided that she wanted to confirm her pregnancy, and she did a serum HCG that was 2,500, and she wanted a consultation and go ahead that she can travel. Right, so Deepa, let me start with you. This lady comes to you and you ask her to have an ultrasound, and this is the ultrasound that she has. Are you happy with the scan, and what will you tell her? Deepa?
Sorry, I have not unmuted.
Yeah.
Okay. So main purpose of doing the scan because of her travel plans, the purpose is to confirm that the pregnancy is forming intrauterine pregnancy. And with this beta both the discriminatory zones, we have to see gestational sacs. We are seeing a thin cystic structures, most with a thin rim of echogenic rims. Most probably it's an intrauterine pregnancy. And with no other problems, we can ask her to come for a review, or we can boldly. We also have plans to travel in a week time, so we can also tell her to travel.
Okay.
Okay.
Okay. So Aditi, you're seeing this when you're scanning. How will you report this?
Hello.
Yeah, I can hear you.
Am I audible, ma'am?
Yes, you are.
I will review her after 2 weeks, ma'am.
No, how will you report it? First, how will you report it?
You can see a intrauterine sac-like structure seen. At present, a yolk sac and embryo not seen. So I will review, call her for a review scan, ma'am.
Okay. So you will call her for a review scan at what, after what interval?
That's for 2 weeks, madam.
Okay, so both agree that they want to see her in 2 weeks, but the issue is she needs to travel in 1 week. So Deepa said it's okay, that's fine. I've confirmed that this is not an ectopic, so go ahead and travel. Yeah? Okay. So
Hope adnexa is normal, madam.
Adnexa is normal. Right? So none of you, so if you go back and look at her dates, so this was 30th of June, we are now on 8th of August. So this is what?
Almost like 6 weeks.
Almost 6 weeks. But we are not seeing something that is akin to a 6-week pregnancy, isn't it? Is that worrying either of you at all?
It's not worrying at all, because the plan of this is not a dating scan. The early scans, what we are doing is around 7 to 8 weeks, is one for viability and to confirm what gestational age. So we normally date the scans in the first trimester screening test. That time, that is around 12 weeks, 12 to 13 week scans. We will do the dating scan. So I'm not concerned about our LMP and delayed conception right now.
Okay. So, Bhuvana, let me come to you, because I'm spending a little time on this, though it's very fundamental, because often women come with a scan like this and ask us, is everything okay? So do you have a different opinion, or you are happy to say everything is okay at this point and go and come back in 2 weeks?
Yeah. Probably I will tell the sac size exactly is not corresponding to 6 weeks, and maybe it is smaller. I would like to know whether she has regular cycles or she has irregular cycles. That also would matter. In case she has irregular cycles, this could be still normal. But if she has regular cycles, maybe this might be a failing pregnancy. We don't know, but we may just say it is smaller at the moment, and we cannot assure till we do a rescan after 2 weeks.
Okay, fair enough. So none of us are terribly worried, but obviously we are registering that this is not what we would expect to see in a 6-week or even a 5.5-week transvaginal scan of a pregnancy, and so we want to review her. But we are happy to allow her to travel. Okay, so she comes back. and this is what you're seeing. She says, I'll postpone my travel a bit, and she comes back. Sorry, the date is wrong. It's 2020. Yeah.
32 weeks.
Yeah, 2 weeks later, she comes back to you. Raji?
Now we are able to make out the yolk sac, appearance of the yolk sac, and also the a good decidual reaction. Chorionic rim also can be seen. So it reassures that it is going in for a viable pregnancy. Now all we need is to wait for the fetal pole to appear, and also the shape of the gestational sac and the yolk sac is looks normal. If it was something like a failing pregnancy, regularity, all that. So again, reassure, check her cycles first of all. Again, reassure and ask her to come back for an review again.
Now, when do you want her again? Doc, I've
See,
already pushed my departure date by 2 weeks because I wanted to know if everything is okay before I travel. Now you're still not certain if this pregnancy is growing normally or not.
no, it looks normal only because
It looks normal.
yeah.
Okay.
So I will, if she wants to travel, means she can travel and get the ultrasound wherever she goes, or
Okay.
here with the gestational good gestational sac and yolk sac appearing, she can get the ultrasound, repeat ultrasound after another 12 weeks, 12 days, or preferably 2 weeks.
Okay. So Aditi, if you had scanned her, you will call her back again in 2 weeks' time. Now?
Ma'am, after 11 days, 10 to 11 days, I will call her to see the embryo, the fetal pole.
Okay. So roughly there, between 10 and 14 days, because we expect that we want to see a fetal pole, and what we are thinking, what everybody's thought process is this is a delayed, conception. Dates may have to change, but as Deepa said, we can't date yet because we are not seeing a fetal pole, and therefore, but none of us are in a tearing hurry to call this a miscarriage. Yeah, we're thinking this is going to be viable. Okay, so the thing was that for this lady, what she was told is that because she had a scan, she had a beta HCG that was positive in on the 2nd of August, suggesting that it was she may have conceived on time. She'd had one scan on the 8th, and 2 weeks later, if we assume this is 4 weeks also, by 6 weeks, normally on a transvaginal scan, we would anticipate to see a fetal pole. And so she came back because she had gone elsewhere in between, and they told her that we are not seeing a fetal pole. We have seen, going back from your LMP of 30th of June, we are now on the 21st of August. This is a miscarriage. So she asked the question, isn't this a change? Are we not seeing a fetal yolk sac? Can we not wait? So the panel here, everybody says we are happy to wait because we can wait another 2 weeks to see if the fetal pole is developing. Correct?
It is another 10 days, madam, because after forming yolk sac, 7 to 8, 10 days, we want to see the fetal pole.
So she's back now. You wanted her after 10 days to 12 days, no? So after 21st, she's come to now 3rd of September. This is what you're seeing.
You can only give us a
There's a CRL, madam.
Yeah,
CRL.
there's a CRL. Or there's a
What
fetal
is the
pole.
measure?
I wouldn't call it a CRL. There is a fetal pole, possibly. It's about, say, 2 mm.
The yolk sac is also 1 millimeter. 0.6 centimeter was a measurement of the yolk sac, and we can see fetal heart with fetal pole of 2 to 3 millimeters. Though the cutoffs are, we have to wait till 7 millimeter to call it as a miscarriage. So, fetal cardiac activity not seen, ma'am, in this. Any comments about that?
No, not seen.
So we can't comment as missed miscarriage till the CRL comes to 7 millimeter, ma'am. Or we have to wait because fetal pole grows 1 millimeter per day. Maybe for benefit of doubt, we can wait for a week's time and then give the confirmed diagnosis. Or we have to wait for it to spontaneously bleed if it is a failed pregnancy.
Okay, what about the rest? Now, how will you report it, Aditi?
Fetal pole seen, but the cardiac means pulsation or is not seen. Cardiac activity not seen yet.
Yeah, so will you commit to a miscarriage now?
No.
You don't want to? Okay. Deepa?
1 more week.
1 more week.
Repeat the scan. Right now, probably it may be a failing pregnancy, but we cannot tell her that it's a failing pregnancy right now. So we have to wait 1 more week to look for cardiac activity. If no, probably yes, missed miscarriage.
Meanwhile, we can do, if suppose such a doubt exists, we can also do a beta HCG.
Okay. And suppose that is what, 8,000 now, what will that help us?
Still, we have to wait for the cardiac activity.
Okay. So, I mean, so basically, I'm just presenting this case because sometimes something as fundamental as telling a woman this pregnancy is viable or this pregnancy is not viable can be challenging. And how can we be definitive that this is a miscarriage? So there are guidelines, and this was a 2011 paper. Basically, I just wanted to highlight this. Before that, the mean sac diameter was 20 mm, and generally they said if the CRL of 6 mm and there isn't a heartbeat, then we would call it a miscarriage. But here they said that when you say that the MSD is 20 mm, there is an inter-observer error which can be as much as 16 to 24, 16.8 to 24.5, and a 6 mm CRL of 5.4 to 6.7. And therefore, the guidance is subsequently got reflected and changed to say that if you have a mean sac diameter of 25 mm without a fetal pole or a yolk sac, or a CRL of 7 mm without a fetal heart, is when you would call it a miscarriage, right? And this is the reason why everybody is very, very cautious about calling this this pregnancy a miscarriage definitively, even though in everybody's mind this pregnancy is definitely not growing well, right? So we have to keep two things in mind. We have to keep that cutoff. The reason being that if you just see a mean sac diameter of 20 and don't see a fetal pole and call it a miscarriage, you may be calling some pregnancies which may eventually grow wrongly a miscarriage. However, in this context, you have different reference points. You have scans from going back nearly 4 weeks. So you saw a documented pregnancy, and which you will assume even if that is 4 weeks when you saw that small sac in the beginning. Now we are 4 weeks from there. And therefore, if this pregnancy was growing well, it should have reached at least 8 weeks by now. So we should see a good fetal pole with a fetal heart, and therefore the possibility that this is heading for a miscarriage, or I may not even have trouble calling this a miscarriage because we have tracked from then to now. But if this was the first and individual scan, then you need to ensure that you have met those cutoffs, and you won't be in a hurry to call this a miscarriage because there is no fetal heart when the fetal pole is 3 mm. Yeah, so there is also the span of growth over which something like this is happening. So because even if that is 4 mm, by now we should have seen a 4 mm or a 5 mm fetal pole with a fetal heart at a minimum. Okay, so this was just to highlight that something as simple as viability can be challenging, but the bottom line is there is no harm caused to the woman in waiting as long as we are able to handhold her and explain her and take her through. Okay, this is a second scenario. She's Mrs. PK, first cycle of the pill, 8 weeks, HCGs 2200, scan was done. Yeah, so this is the uterus, and these are the two adnexa. Raji, you want to start?
For 8 weeks pregnancy, I'm not able to see the gestation.
Yeah, we are not
Gestational
seeing
sac,
the gestational sac.
gestational sac, and HCG levels are not correlating or lesser. First of all, I would like to see whether she had any spotting or bleeding, and also
No
any
symptoms.
abdominal pain.
Regular,
No
I mean,
symptoms.
first cycle of the pill, before the pill, her cycles were regular and no spotting, no bleeding. She's just done a HCG to confirm pregnancy.
Okay. It doesn't show any intrauterine pregnancy with the low levels of HCG. So I would like to, and the endometrial, the echoes are also heterogenic. It looks like either she would have passed the product's miscarriage. Still, I would like to rule out, see the adnexa carefully and look for any ectopic.
Okay. Okay. So there's no history of bleeding. So the message here is you're seeing 2200 HCG. We should be able to see a sac. If we haven't seen a sac, either she's had a complete abortion and we are seeing a residual endometrium, or we are not yet seeing an ectopic pregnancy. So they need to carefully look at that nexa. We looked as hard as we could and we couldn't see anything. So what will you do to her next?
After 1 week.
Deepa?
Since she's asymptomatic and very stable, we can easily review her after 1 week to look for adnexals. Maybe you can also do a repeat beta HCG after 2 days for whether it is increasing or it is failing beta HCG if she is completely aborted.
Okay.
So there are two options. I will repeat the beta HCG. I will review her after 1 week for a sonography.
Okay. So repeating the HCG. Bhuwana, which would you?
If we see her after a week, we will miss the chance of medical management in case if it's ectopic. So I would review her with the beta HCG and see how is it doubling and what is the percentage of increase of beta HCG in 48 hours. And if I see a good raise, or maybe I'll redo the scan within 2 days to see.
So here you have 3 days, just as you asked. HCG is 3450. Aditi, you've done an ultrasound. You're not seeing an intrauterine sac. You've looked as much as you could and you couldn't see anything in that nexa. How will you report this?
Can you repeat?
So you've done a scan. So you've done a scan when the HCG was 2200. You couldn't see a sac anywhere, right? The obstetrician said, I want to repeat a HCG in 3 days, 2 to 3 days. 2 to 3 days, HCG is repeated and it is 3450. So they send her back to you and say, now please identify this sac, because with a HCG of 3000, you should be able to see a sac, isn't it? But you have looked as best as you can and you can't see a sac. So how will you report it?
We will try to look in detail the adnexa and all and rule out the ectopic pregnancy, and also look at the endometrium, the decidua and all, and we can give it as a PUL, pregnancy of unknown location.
Okay. All right. So this lady actually was counseled for methotrexate with a diagnosis of possible of a pregnancy of unknown location, possibly an ectopic, because we couldn't see a sac even with a HCG of 3400. We were hesitant to do it the first time because in the off chance of a intrauterine pregnancy that's not yet seen, you don't want to give her methotrexate right away.
At this point of time, if I had been, I definitely would have given methotrexate, though ultrasound is not showing adnexal mass. With the beta HCG of 3450 and with advanced ultrasound machines available, we should have seen an IUG, yes.
Yes.
So if we delay that, then there is a chance that even ectopic is not seen, we will fail to cure it by medical management.
Right.
I would like to give methotrexate.
Yeah, which is what we did. We counseled her for methotrexate and told her that she needs to take it. She was very, very reluctant to take methotrexate and wanted to wait. And she went away, came back only after 6 days saying, I want one more scan, after which I will take the injection. So at this point in the left adnexa, an ectopic became visible. But this is only because she opted not to take the methotrexate. That the message is that if you don't see a sac when the HCG is over 3000, definitely we need to consider methotrexate. As Bona said, otherwise we run the risk of a rupture happening somewhere. Yeah. Okay, so this was the ectopic. So if she's symptomatic, obviously we will go in and manage. Because she's asymptomatic, we repeat the HCG, see whether there is an increase. And if there's a definite good increase, there is a possibility that there is an intrauterine pregnancy. If the increase is less than 15% or it is dropping, then you can manage conservatively, because it could be a failing pregnancy wherever and therefore may not need anything. But if there's a suboptimal increase, then definitely we consider and take a methotrexate. Okay. So, Raji, coming back to you, this is a lady who has had a previous cesarean section 3 years ago. Now, early pregnancy scan, some abdominal discomfort she complained, and so the early pregnancy scan was done. And it's reported as a low-lying sac.
So the report comes as a low-lying sac, either it could be a scar, pregnancy in the scar, or it could be an either she could be aborting, and also we have to rule out cervical pregnancy.
Okay, fair enough. And do you anyone tell me how you will differentiate a cervical pregnancy from a scar pregnancy?
Here the sac is situated well above the internal os, ma'am. This is the cervical canal, what I'm able to see. This is the internal os. The sac is located quite well above the internal os, which tells it is not cervical pregnancy. It's only either low placed, or how to differentiate whether it is a lower placed sac or a scar pregnancy is here. We have seen the endometrium and intrauterine cavity looks empty, and the sac is well away from the endometrium. It is almost into the myometrium, close to the bladder. However, I am able to see some amount of thickness of the myometrium here. So maybe it is extending more close to the cavity, not a very dangerous type of scar pregnancy. Those scar pregnancy have to be ruled out.
Yeah.
Also good blood flow, good vascularity.
Yeah.
Yeah. Yeah, so I think both those differentials are important for us to keep in mind. The fact that it could be a miscarriage that is happening and therefore the sac is seen low down. In that case, generally you won't see so much vascularity, and it will also be within the cavity. You won't see it going into the myometrium. Cervical pregnancy, identify where the cervical os is. It shouldn't be, and it shouldn't be within the substance of the cervix. There should be. So in a cervical pregnancy, you won't see it just within the lining, and then you can see whether it's burrowing into the myometrium or not, and that will tell us whether this is going to be a scar pregnancy, the differential of a scar pregnancy. Sometimes it may, if we don't pick it up very early and we allow it to grow, we end up in trouble going on further. Sometimes when we are not sure, we may review in a week or 10 days to see what actually is happening. Okay, so now moving on to a set of 2 or 3 scenarios which are to do with first trimester screening. So this is a primip. She's 22 years old. She's had a first trimester screening done. And, she's had pre-test counseling telling her that this is to detect her chance of having a baby with Down syndrome. And so this is how the report comes back as. And you can see that her risk of trisomy 21 is low, but the risk of trisomy 18 and 13, the risk of trisomy 18 is 1 in 5, and the risk of trisomy 13 is 1 in 119.
So she is having an increased risk of trisomy 18.
Yeah, so she's there, she's come back to you. And how are you going to counsel her now?
So we have to look for other markers in the first trimester screening test, like other soft markers like rocker bottom feet and the clenched feet of trisomy 18. And
none of that is there. Whoever, one of them, either Deepthi or Sudarshan or Malti has scanned. So it's,
there is no other
ultrasound. They have not raised any flags about this baby being structurally having a problem.
Even if there is no structural abnormality in the first trimester, trisomy 18 will definitely have problems in the second trimester, madam. But we cannot wait till that period. I would like to definitely offer either amnio or NIPT. Second trimester, we will definitely see cardiac or diaphragmatic hernia or any other issues of if it is Edwards. But we cannot wait.
She's about 13 plus. She's sitting in front of you.
Can offer NIPT, or she can wait and do amnio a little later, maybe 15 to 16 weeks. A genetic sonogram, a early focused genetic sonogram in the second trimester, looking for other soft markers to develop. We can look at that also.
Okay. Any other opinion?
PAPE is low in this patient.
Beta is also low.
PAPE is low.
Beta HCG is low. Placental cause can be there for low PAPE.
Which is driving the 18 risk, you're saying?
Yeah. Yes, ma'am. But beta HCG is also low, ma'am.
Yeah. Beta HCG is low, PAPE is low.
Maybe we can do an early anomaly scan at 16 weeks and then offer amniocentesis.
Offer testing. You won't rush to offer her a CVS now.
So we need to give an extensive counseling at this stage. That we have to explore the options. We can give her option of us Bonacides, NAPT, and choreo. But looking into that, the sensitivity of FTS to detect the trisomy 18 is like 70%, not like a Downs, which is 90%. So looking into the placental factor is also there. Maybe we can wait up to 16 weeks to go for the definitive testing.
Okay.
After giving an extensive counseling.
See, usually patients are very anxious. They don't want to continue if we tell some chromosome thing. So better to do counseling and do a NIPT as early as possible or amnio. Otherwise, they will come and ask, why didn't you could have suggested all this, no?
Yeah. Okay, so the reason I put up this case is one, because very often when we do pre-test counseling, we only inform or we are only talking about trisomy 21 to the couple. We are telling them we are doing this for T21. We also have to tell them that yes, primarily we are doing it for T21, but T18 and 13 also get screened for, so that when we get a report like this, they are not worrying, now you never told us about this. Right, so this is something that I wanted to say, and we need to also look at this. So yeah, so the message that we are getting from the panelists is that majority of babies which have trisomy 13 or trisomy 18 will have a structural abnormality, but there is a small percentage where there may not be a structural abnormality, in whom we may see a growth lag or something developing later. So we have the choice of doing an invasive testing now versus waiting, doing an early tag, because she's already almost 14 weeks by the time all this result has come. Can say just wait for another 2 weeks, we will do an ultrasound. That ultrasound may pick up something that is happening and then we will offer you amnio so that we have a definitive answer. Now, with NIPT, the reliability is much better for T21 than it is for T18. So the choice is between waiting, and as Deepa said, you need a fair amount of counseling to ask them to wait and then repeat the test. Okay, now this is now if she's tested, and that's I think the point that one of the maybe the reason why Aditi highlighted the fact that your PAPA is low, because in this situation a formal preeclampsia screen has not been done. This is an older case. So if she does have a structurally normal fetus and an invasive testing has been done in which there is no Edwards, then definitely her risk for preeclampsia is going to go up. Therefore, if we are deferring this whole process to 16 weeks, we need to start her on aspirin at this point. However, the current recommendation is not to start just based on one marker, but I'm just saying that if you had done preeclampsia screening, very possibly she would screen high for preeclampsia as well. And if she doesn't have Edwards, then we need to follow her up for placental dysfunction and IUGR because of that PAPA being 0.11. Okay, now this is another scenario. This is a 32-year-old and this is her markers. Aditi, do you just want to walk us through this?
Yes, ma'am. So she has 12 weeks, 3 days pregnancy with an PAPA mom of 0.22, beta SCG mom 0.54. It has she has done an enhanced first trimester screening, which includes the pre-eclampsia screening also. PLGF is 0.23 mom, and preterm pre-eclampsia risk has come as 1:115, which is an increased risk. So we can offer aspirin to the patient, 150 milligram HS till 36 weeks of pregnancy.
Okay. So anything more that you would like to do for her? So you've initiated her on aspirin. Is that enough? Are you happy? Anything more you want to do?
We can
she comes back with this report to you with the recommendation that she be initiated on aspirin because of an increased preeclampsia risk.
So other factors, other renal evaluation.
Better follow up for growth restriction or something, like better be vigilant for.
Okay.
She's likely having a higher BMI and she's aged 32, I think, born in 1990. It is 2022, must be 32 years.
Yeah.
And she's BMI is also high. Apart from aspirin, I don't think I'll start on any other.
Yeah. So definitely, I mean, I'm not suggesting we should start on anything else. Aspirin is what we will start her on, 150 milligram at night. You probably need to give her a little bit of dietary advice, weight gain and things like that, and warn her about the risk of preeclampsia and increase surveillance for the fetus with an additional growth scan in between to ensure that this placental dysfunction doesn't also result in growth restriction. So this this is somebody that we need to watch quite carefully. Okay, now this is another scenario. So this lady is 33 years old. She's a previous normal delivery 6 years ago, and she's had her first trimester screening, and the screening risk comes back with a risk of 1 in 33 for Down syndrome, and she's screen positive, right? And she's sitting in front of you and you're telling her that this is the probability is higher, and therefore you offer her testing, and she says, I don't want to test. So how will you respond to this situation?
This, I think the risk has increased because of absent nasal bone, madam. Though NT PAPA is within normal limits, beta HCG should be more than 2 moms or something. PAPA should be low. So biochemical markers wise, they look normal. NT is also okay, but nasal bone is absent, due to which I think the risk is increased. Because of 1 in 33, the chances, we will explain the chances of 1 in 33 risk of having a Downs, and we have to explain it's important to go through either NIPT or amnio.
Yeah, I'm listening to what you're saying, doctor, but I have one normal baby. My gut instinct is this baby is normal. So I really don't want to have any further testing.
If it is
I
so,
want
then
to know
we have
how
to,
you will respond.
we have to document, ma'am. We have to document that she's not willing for explained about the risks of Downs, and patient understands the procedure and not willing to undergo any definitive testing. However, counseled her to go for a second trimester ultrasound to look for any markers like short femur or short humerus, pilectasis, or echogenic cardiac bouquet or echogenic bowel, to look at any other marker. At that point of time, maybe we can offer, look at the cardiac. Maybe we can tell at that time also, but sometimes we may not be able to detect in the second trimester also. If she refuses, we have to just document what more we can do.
Okay, any other thoughts?
Can offer NIPT because the detection rate is high, and tell about the
She
detection rate
refuses
that
for
we
any
can
test.
Fair enough. So
NIPT
if she's worried about invasive, generally when the risk is greater than 1 in 50, we tend not to offer NIPT. However, as Bhuvana also highlighted, since most of the markers are in the normal range, but her age is 33 and nasal bone is absent, is why probably this has gone up. If you are offering her NIPT, then you have to document, but this lady declined that also. She just said, I don't want testing. So yes, I mean, this is a conversation to be had to make sure she understands that she's declining. Most importantly, that they don't come back at 20 weeks and say, now I want a test. So that is something that it's a, you know, whatever we say, they have to accept it. But the point that was made is that you could do, you could look at her anatomy scan, probably do it at 18 weeks. And then based on the markers there, see whether her risk goes up or down. But it's unlikely that it will fall within a low risk range when it is starting at 1 in 33. But it may down regulate, but not significantly. So it may not change. So the key is that she doesn't come back at 20 weeks or 22 weeks with a worry, because then we'll be quite stuck about what test to offer. What we definitely don't do is offer her a quadruple test on top of this or any other testing. We either do an invasive testing or, if we are offering NIPT, we have to go through the fact that it is not a definitive test, etc., and why we would offer an invasive test over an NIPT. And so I just highlight, because once in a while it happens. We have couples who and pretty much the same thing happened to this lady at 18 weeks. Though that scan was normal, by that time she got worried because they read and their thing, and she requested testing at that point in time. So then again the same options were offered to have an amnio, and the whole thing got delayed further. The baby turned out to be normal. I mean, the testing turned out to be normal. So okay, how are we on time? Okay, we'll just do this one quickly. This is a 29-year-old who conceived on ovulation induction and IUI, and she was seen at 6 weeks to confirm viability, and there was a cardiac activity seen, but she was asked to review in a week because I'll tell you why. Because and she came back in a week. This is what was seen, and the reason the doctor asked for her to come back is because even though there was a CRL, she felt that there was it was wider than usual when she measured it at 6 weeks, and therefore she told her to come back, and this is what we saw. I'm putting it here because it was very unusual to pick up this at 7 weeks of pregnancy. So if you see here, this is measuring a CRL, but here you can see what looks like two babies at one point and a single baby at another point. And indeed, this was a pickup of
Conjoined twins.
conjoined twin
Conjoined twins.
that was made very, very early at 7 weeks and 6 days. And then we spoke to the couple and we told them that this is a strong possibility, but it's an extremely early pickup, and therefore to be absolutely sure that this is what we are seeing, we asked her to come back in a week. And at that time, when they put, because it's very early, there is still no crown rump. I mean, the crown rump differentiation is just happening. You can see that the cardiac area is what is shared. So this was a pickup at about between 7 and 8 weeks. So this was 8 weeks and 2 days. And how do we talk to this couple?
Looks at it is probably thoracophagus. Maybe operability and separation of the twins is difficult. So maybe we will offer a termination.
Yeah, fair enough. So this was, the couple actually asked whether separation was possible. And we had to say that it's very, very early for us to say what is shared and what is not. But looking at this, it looks like the thorax is fused, which means that it will be very difficult. So they wanted time to think about it, and ultimately they decided to go ahead for a termination. So sometimes it's a surprise, and I'm not putting it up here for the rarity, but for the fact that when the CRL is measured, even when it is some extremely simple measurement, paying attention to how it looks, are we seeing a greater width? Is there something that doesn't look exactly normal? Is the only thing that will flag something like this, calling a recall and for a pickup, because this is extremely rare. Yeah, but just to say, let's not be very casual about a CRL measurement. Many times we are. Many times it's just done without even a documentation, without a measurement, and then we miss the opportunity for early detection. So that is the point that I want to make. I think I do have another case, but I don't know if we have run out.
We have time, ma'am.
Okay. All right. So this is a 32-year-old, 4 years of infertility, was offered myomectomy after 2 failed IUI cycles, but had a spontaneous conception, and she presented for antenatal care at 11 weeks. And this is what we are seeing. So this was the fibroid. So there is a myoma which is about 11.9 into 2.3 centimeters with these cystic spaces inside. So Rajesh is now pregnant and this fibroid is there.
Yeah,
she's worried.
Looks like I would ask her if she's having any symptoms, any pain, and it looks like a myoma which is degenerating.
Yes.
So only thing we have to explain what it is. Since quite early we cannot intervene. Also we cannot do any intervention. Reassure her, giving analgesics, and just wait and watch. And if she has any other, I don't know the location of the myoma, any spotting or anything. And also I would like to follow her up for the fetal growth and also the placental position.
Yeah.
And any premature separation, any abruption. So just I would not like to scare her, but I would just like to brief her. These are all the things which might happen to her.
Okay. Yeah.
So as of now, just rest and follow up.
Yeah. Thank you. So this was an intramural, fibroid that was projecting outwards. It wasn't anywhere near the cavity, but there was evidence of degeneration, and she was having some pain and discomfort. So any role for any medication?
Medication other than analgesics and rest, I don't think so any medications will help, because she's pregnant out of infertility, and this she may worried about at this stage a miscarriage. Progesterone, it's like a debate whether it will be useful. It's a very, very long debate. Circlage is no. Reassurance and follow-up. If it is extremely pain and patient is in shock, then may probably roll off emergency myomectomy. That is the only indication for myomectomy.
Okay.
Otherwise, no.
Okay, fair enough. Okay. So yeah, I think this is all. All of this is what you said was what was done, and this lady it's an ongoing pregnancy. She's now about 28 weeks. The baby's growing well. She's come in twice with episodes of pain, which have been managed with just paracetamol, admission, reassurance. But baby's growing well at 28 weeks. Okay, so this is the last scenario, 25-year-old primey, spotting and lower abdominal pain. So she's had an ultrasound done. You can see a nice happy baby with a good fetal heart, and this is what you're seeing in the adnexa.
There is a complex echogenic adnexal mass. I feel it is sickle shaped, maybe dermoid, I don't know. Maybe you'll offer MRI also to confirm. Not able to see solid area, but this crescent shaped shadow, maybe it is a dermoid. If there is pain, definitely we need to proceed with MRI to look at the inner features of the cyst to rule out any solid areas and add on with tumor markers also.
Okay, all right. Any other opinion?
If it comes as a dermoid second trimester, we need to.
No, she's early pregnancy. She's only maybe 8-9 weeks.
So now
there is no
we're not
pain,
doing anything.
We will just observe till the first trimester is over. If a confirmation of the this thing is dermoid.
Now there is a good ultrasonographic distinction of benign and malignancy. So if there is no solid components, no papillary projections, no thick contentions, if it is looking like a benign and only pain symptoms, we can wait. Only problem in waiting is like torsion and severe torsion in a benign ovarian or rupture and severe pain. Probably we have to go and intervene. And if it is a malignancy, as the tumor markers have a little less role, because in pregnancy, it is an young age. So even germ cell tumors, other tumors, the tumor markers may not give it does not benefit for us, including a CA125 or germ cell tumor markers. So going with only with the malignancy features of ultrasound as and on top of it, we can have an MRI features if your ultrasound is not very clear. Just because to rule out malignancy.
Okay, fair enough. So I think early pregnancy, if you have a good quality ultrasound and there are no features, and as Bhuvana has mentioned some of the features of a dermoid that are visible, and Deepa has highlighted that markers may have limited value. So this was a dermoid, and there were no other malignant signs, and pattern recognition basically was what made the diagnosis. So the pain was not acute. We did warn her about torsion, but said that it's unlikely that this is going to affect the pregnancy.
Can offer laparoscopic ovarian cystectomy in the mid trimester, because if they don't, it's considering the size of the cyst, because if they go into the third trimester, doing a laparoscopic torsion becomes very difficult. So I usually offer in the second trimester if they wish to take up the laparoscopic.
Practically, if you see this kind of, when the pregnancy is going in the rapidly increasing, the first trimester only the torsion will be common. Okay, so I experience most of the torsion is happen when the pregnancy is 9 weeks.
No, I agree, but when
so in case of emergency, probably we have to intervene at any.
We had a case at 32, 34 weeks pregnancy with the torsion, and we did an open, laparoscopy, and very carefully we did it at 32 weeks size, and doing a laparoscopy in advanced pregnancy is difficult.
Big challenge.
Instead of waiting for an emergency, I think better the second trimester we can intervene and remove it, seeing the size of the fiber, I mean size of the dermoid.
Yeah. Okay, so that is a dilemma. So if the pain is persisting, I think then it becomes an indication, clear indication for going in and removing. But if there is, mute, please. If we don't have, I mean, if there's no symptom, then the dilemma is that do you offer surgery in pregnancy for an asymptomatic dermoid, which has probably been there for a very long time, or run the chance of running into trouble in the late third trimester. Though I tend to agree that majority of the time torsion happens in the first trimester, and more importantly in the postpartum period, because as the uterus is involuting in the postpartum period, they are more likely to tort. So if we are not doing anything and she delivers and it is not a section and she delivers vaginally, we need to warn them and ask them to watch out for pain and come in, because otherwise
Purely luck, madam. We have to just wait. She should be lucky that it should not undergo torsion.
Yeah, fair enough. Yeah. Okay. So I think that brings us to the end of the cases. I thank all of you for being very, very interactive and good panel, good discussions that have come out.
Interesting scenarios too, ma'am.
And
enjoyed it.
I hope that is what Hepzibah wanted.
Thank you.
Thank you for
Dr.
the
Uma. It was very informative, interactive, detailed. Giving apt and crisp messages was sent across. No confusion. Confusion to clarity. It was very interesting and information and very useful. Thank you so much. You have taken much.
And it was not rehearsed in that sense at all. So I think we must thank them for all thinking along the same lines and bringing it together nicely.
Yes.
Yeah.
That shows their experience.
Yes.
Okay. Thank you so much. I think with that, Archana, can you say word of thanks?
Yes, ma'am. Sure, ma'am. Good afternoon, one and all. As we have come to the closure of the webinar, it's my privilege to prepare a vote of thanks on behalf of organizing committee, Saveetha Medical College.
Turn your video, Archana. Okay.
My heartfelt gratitude and respect to our guest of honor, Dr. Deepika Dekar, ma'am, distinguished chairpersons, Dr. K. Jayashree, ma'am, Dr. Parimala, madam, Dr. Nidhi Sama, ma'am, Dr. Shiva Sundari, madam, and Dr. Rajalakshmi, ma'am, and Dr. Umaram, ma'am, and our eminent speakers like Dr. Dipti Jami, ma'am, Dr. Marathi Prasad, ma'am, Dr. A. Sudarshan, sir, Dr. V. Rajalakshmi, ma'am, Dr. Deepa Tangamani, ma'am, Dr. Bhuwana, ma'am, and Dr. Aditi Dubey, ma'am, for not only sparing their valuable times for us to face this occasion, but also for enlightening us with their commendable talk on the subjects. Thanks all of you for clearing our concepts and enhancing our understanding pertaining to the sonographic assessment of fetal anatomy in first trimester, role and limitation of ultrasound to detect fetal anomaly, and downstream awareness. And the last session, like such a informative session and a very good discussion of the case-based discussion. And no event can take shape without a leader. We extend our heartfelt gratitude for our honorable founder, Chancellor, Dr. N.M. Virayan, sir, Director, Dr. Saveetha, ma'am, Organizing Chairperson, Dr. J. Damodran, sir, and Vice Chairperson, Dr. Chitra, ma'am. Above and beyond, let's not forget the backbone of the webinar, our Organizing Secretary, Dr. Hepzibah Kirubamani, ma'am, who is very much interested in all academic activities. Last but not the least, I would like to thank Vinno for all this technical support, and I apologize if I would have forgotten to thank anyone. Have a wonderful day, ma'am. Thank you so much.
Thank you.
Thank you.
Thank you. Thank you. Thank you, everyone.
Thank
Thanks
you,
a lot, Puna.
Thank you, ma'am.
Aditi.
Thank you, ma'am.
Thank
Thank you so much. Enjoy.
Thank you, ma'am. Thank you.
Bye-bye.
Thank you.
Thanks.
Bye. Bye. Bye.
Bye.
Thank you. Thank you.